you can see with 20 gray times 1, you don't see any really change in the secondary tumor. However, when you use H gray times 3, you see a significant growth delay in the unradiated tumor. And when you use 6 gray times 5, you also see a drop of the size of the unradiated tumor. So this basically showed that fractionated treatment appears to do a better job in enhancing the abscopal effect from radiation. So what was really interesting was that the same lab was able to fold the mechanisms of how that happens. So basically, the mechanism goes as following. So when you radiate a tumor, we all know that we generate double-stranded DNA fragments. And those double-stranded DNA fragments can trigger a STING pathway, which lead to interferon induction and immune response within the tumor. So this is basically how radiation can turn tumor into an in situ vaccine. However, that effect is dose dependent. When you go beyond 12 gray, you do not see really those double-strand DNA fragments. The reason is that at that dose, you induce the production of an enzyme called TREX1, which chops up all the double-stranded DNA fragment. So that is why when you use a single fraction large dose, you do not induce a very strong immune response. So these studies provide evidence to use fractionated treatment to generate a better immune response than single fraction. So I thought this was such a beautiful story, from the initial observation to uncovering of the mechanisms. Now moving on to the role of brain radiation in the era of immunotherapy. So 2 years ago, 2 phase 2 trials published in New England Journal of Medicine examining the efficacy of EP and nivo in the treatment of melanoma brain metastasis. So the first trial was led by my medical oncology colleague at MD Anderson Cancer Center, that's Dr. Taubey. So this trial basically showed that ipi-nivo is associated with an intracranial response rate of 56%. They also find this intracranial response basically parallels the extracranial response, but a little bit less, about 10% less. And they also found in patients who responded, the response tend to be durable. So the second trial was led by Australian group. They basically showed similar results with the intracranial response rate of 46%. So these studies has led to many medical oncologists to believe that the standard of care of melanoma brain metastasis should be ipi-nivo. And they stopped referring patients for radiation. So the question is whether a phase 2 trial with a response rate of 50% good enough to de-escalate management of brain metastasis. Is it enough to omit a standard of care of SRS, which has a local control of 70 to 90+%? And when you look at the literature with SRS combined with immunotherapy, the local control is over 90%. So should we hold the radiation because of intracranial response rate of 50%? So my answer is no. I think we need evidence to really delineate the efficacy of radiation in upfront setting and salvage setting. So another concern I have with omitting upfront radiation is that about 50% of the patients do not respond in the brain. We have no way at this moment of identifying which patient is going to respond, which will not. So the question is, when you omit radiation in those patients and you treat them at the time of progression, did we miss the best window of opportunity to achieve intracranial in those patients? So in my opinion, a phase 3 randomized trial comparing upfront SRS and salvage SRS in the setting of immunotherapy is needed. As far as I know, NRG is evaluating those concepts. And also it is important for medical oncologists to know that when you run a trial for brain tumor, it's important to include brain tumor specific endpoints such as cognitive function and prevention of additional treatment. So there are many very good rationales to combine radiation and immunotherapy. For example, as I mentioned earlier, radiation potentially turn tumor into in vivo vaccine by promoting tumor antigen release and stimulating T-cell mediated immune response. On the other hand, immunotherapy can turn radiation from local therapy to systemic therapy by enhancing radiation-induced abscopal effect, which is extremely uncommon on its own. So there are some evidence to actually support the combination of the two. And this is a study published by my medical oncology colleague, Dr. Davis from MD Anderson Cancer Center. So he did a molecular profiling of paired brain met sample and extracranial sample. And what I'm showing you here is actually only a small fraction of his publication. So what he was able to identify was two populations of brain metastases, one with high immune infiltrates and one with low immune infiltrates. As you can see on the left side, the tumor cells, the brain metastasis with high immune infiltrates is associated with better survival. And when he was trying to identify what patients tend to have high immune infiltrates, and the only factor that he was able to identify was prior radiation. So basically, radiation is associated with higher immune infiltrates in the brain metastasis, which basically is the a more robust inflammation of those metastases, which in turn is associated with better survival. So another line of evidence came from one of our very talented residents who studied the overall survival of melanoma patients who received concurrent immunotherapy and SIS. It's a retrospective study. So we defined concurrent treatment as treatment of radiation and immunotherapy started within 30 days of each other. Specifically, he identified a relatively cleaner population of patients with newly diagnosed melanoma brain mets who received no prior immunotherapy or SIS. So he was able to show that in this patient population, those who received the two treatments within 11 days of each other have better overall survival as shown on the left side and a better distant brain control as shown on the right side, as compared to patients who had an interval of 12 to 30 days between the two initiation of treatment. So basically, if you gave two treatments close in time, the patients are more likely, and I should say there is association between the better overall survival and the brain control if the two treatments are delivered within a shorter period of time. We did look at the sequencing of the two treatments. We did not see a difference. It's likely because the small sample size. Not surprisingly, we observed increased radiation necrosis when immunotherapy and SIS were delivered within a short period of time. So for patients who had two treatments within 11 days of each other, the risk for radiation necrosis is about 26% versus about 4% for patients who have a longer interval. And this is actually consistent with our previous publication showing that the rate of radiation necrosis is about 27% in melanoma patients who are treated with ipi-nivo and SRS. So this has been used by many of our medical oncologists as a reason not to offer brain radiation. And so my belief is that that really should not be used as the reason to not offer brain radiation. The reason is that, number one, radiation necrosis does not always cause symptoms. And in patients with symptoms, it's highly manageable. So it's a very manageable side effect. And in this slide, I'm showing you our management algorithm for suspected radiation necrosis. So we basically do not do anything if the patient does not have symptoms. If they have symptoms, we start with steroids. If they become steroids resistant or refractory, we do different imaging studies to give us some idea whether those patients will have radiation necrosis or tumor recurrence. Based on the imaging results, if patient we believe they have radiation necrosis, we start treatment with Avastin or laser ablation. If they had recurrent tumor, oftentimes they go to resection if it's resectable. If it's not, they get laser ablation. So it is a very highly manageable side effects. And also for all the data that I've shown you so far, the radiation necrosis represents an inflammatory response. So it might actually indicate better survival for those patients. So if I'm a patient, I would rather to deal with the side effects of radiation or radiation necrosis and have the tumor controlled. So we therefore launched a phase 1/2 trial 4 years ago, evaluating the safety and efficacy of concurrent nivo-ipi with brain radiation. So the radiation can be either SRS or whole brain radiation as determined by the treating physician. And the concurrent treatment is defined as initiation of treatment within 7 days of each other. We didn't define the sequence. Each treatment can start first. And the DLT is defined 15% of intracranial toxicity or 30% of extracranial toxicity assessed at 8 weeks. So we have completed the phase 1 portion of the SIS cohort, and we will be presenting these results at upcoming ASTRO. Basically, we did not reach the predefined DLT, indicating that it is safe to combine ipi-nivo and SRS for non-small cell lung cancer patients with intracranial metastasis. So the completion of this part of the study is very timely because earlier this year and also later last year, the 2 phase 3 randomized trials were published, establishing ipi-nivo as the first-line treatment for non-small cell lung cancer, advanced non-small lung cancer. So in the first trial, nivo-ipi was compared to chemotherapy and showed overall survival benefit. In the second trial, the comparison was made between nivo-ipi with 2 cycles of chemo versus chemo. And again, it showed overall survival benefit compared to chemotherapy. So as we all know, as ipi and nivo are anticipated to be used more as a first line for non-small cell lung cancer, and we know those patients tend to develop brain metastasis. So we are happy to be able to provide the phase 1 data to support the use of ipi-nivo with SIS. So now moving on to the fourth area of interest, the role of brain radiation in the era of CNS penetrating target therapy. As we all know, more and more target therapies have shown intracranial activity. Those include BRAF and MAP kinase inhibitors for melanoma, EGF receptor and ALK inhibitors in non-small cell lung cancer, and HER2 inhibitors for breast cancer. So first, I want to draw your attention to this retrospective studies led by Dr. Veronica Chang from Yale, inclusive of data from 6 institutions. So in this particular study, they looked at the patients who are eligible for EGF receptor inhibitors. They compared the overall survival of patients who received upfront radiation, whether SRS or whole brain radiation, versus those who were not receiving upfront radiation. So what they found is that there is association between omission of brain radiation and worse overall survival. So basically, patients who did not receive upfront radiation are more likely to die and die early. So, and I have used this trial to really caution my medical oncologist colleagues about omission of upfront brain radiation. However, that issue became a little more complicated because the newer agents have shown better CNS penetration, therefore better CNS activity. For example, Tagrisso has been shown to be better than the standard EGF receptor TKIs, and in this phase 3 trial, and they observed a similar benefit in patients with treated brain metastasis, suggesting that Tagrisso have activity in the brain as well. Along the same line, in a recent published phase 3 trial in HER2-positive breast cancer, we similarly observed intracranial activity with tucatinib. So this is a trial in HER2-positive breast cancer patients. The patients were treated with the standard of care of Herceptin and Xeloda, without tucatinib, which is a HER2 inhibitor. What's unique about this trial is that they allow patients with treated or untreated brain metastasis. And this trial is positive. It showed overall survival benefit with the addition of tucatinib. So what I'm showing you here is the subpopulation of patients with brain metastasis as shown on the left side. They observed overall survival benefit in this population, suggesting that tucatinib has activity in the brain. In addition, they also look at the patient population where the brain metastases were not treated with radiation. So those are the patients with untreated brain metastases. And as you can see, tucatinib is associated with better survival, meaning that it has intracranial activity as well. So again, we are at a time that we have, it is absolutely fantastic that we have more and more target agents that can penetrate into the brain and show efficacy in the brain. And the question still remains, can we safely hold radiation? So at least for the retrospective studies, we have learned that the holding of intracranial radiation can potentially lead to worse survival. And again, in my opinion, I think we need phase 3 trials to test that question. So in summary, for patients with multiple brain metastases, we have level 1 evidence to support the use of hippocampal avoidance whole brain radiation with memantine. And we also have emerging evidence, if confirmed, to support the use of SRS. So the next question is, among those 2 options, which one is better? So we have a Canadian trial that is ongoing to test that question. So the second one is the management of resection cavity. We have level 1 evidence to support the use of post-op SRS as the standard of care for the surgical cavity. We are evaluating the benefit of pre-op SRS in terms of reducing LMD for resectable brain metastasis. And also the best SRS regimen is being evaluated in an alliance trial. So in terms of whether we should deliver radiation or not in patients getting immunotherapy. And this is basically very controversy issue. And in my opinion, I think we need phase 3 randomized trials to test the question whether the radiation can be safely omitted or not, or deferred. So fortunately, I believe NRG is interested in those concepts, and hopefully we will see trials ongoing in the near future. And lastly, we're facing the same issues with patients receiving CNS penetrating target therapy. So the question again is, can we safely hold the radiation in those patients? Or should we combine the treatment to give a better intracranial control for those patients? But at the same time, we may put the patient at a high risk for toxicity. So I don't know the answers to those questions, and hopefully, again, I would like to see a phase 3 trial to address those questions. Okay, I'm going to stop there. Thank you very much for your attention.
Thank you, Dr. Lee.